So I'd like to just then introduce Dr. Chris Green. The title of her presentation is From Bedside to Bench, a Clinician's Journey in Caring for Patients with Tick-Borne Infections. And similarly, her bio sketch is listed, her biography, and I like listening to Chris Green because she's a clinician and she's taking care of many patients, and she's got a great experience with managing patients over the year and teaching healthcare workers, and I think this is this lecture here is really valuable for everybody, but it's especially valuable for primary care doctors, I think, to better understand the complexities of Lyme disease. It's not easy to diagnose, easy to treat. 2 weeks of antibiotics, Bob, your uncle, you're cured. It's much more complicated than that. And I kind of look at Lyme as the model of infection, damaged immune system, inflammation. It's a complex cascade of infection and a trigger of other conditions that contribute to the complications of Lyme and the other infections that we're dealing with. So I'll stop now. Thank you, Chris, for coming, and we look forward to hearing your presentation.
So good morning, and thank you, Dr. Lambert, Dr. Perrone, for inviting me. I'm very excited to be here. And I did entitle this From Bedside to Bench, kind of a clinician's journey to treating an emerging disease when the evidence of that disease hasn't emerged yet. I do this in the hopes to, one, let you know how that works with my practice as the example, and also hopefully to identify what further research is needed, what we need from the bench and from the clinical studies, and also to really illustrate the importance of including patients in our decisions about what we're going to investigate and what outcome we are looking for. I really have no disclosures. So the first patient in my practice with Lyme was in 1989. He walked in, or he limped in. He couldn't control his leg, one of his legs, and he looked, for all intents and purposes, like he had MS. The workup was relatively benign. I had asymmetric reflexes, normal blood work, and so as a primary care, you refer to your specialist. Looked like he had neuro disease. I referred him to a neurologist and a second neurologist and a third neurologist. And they all said, looks like MS isn't MS. You figure out what it is. So I had a male with an atypical presentation. At that time, there was no internet. Now I think, warning, now I think our challenge is figuring out what all that information coming from the internet, what's accurate, but then it was finding things out. So of course I hit the medical library. I asked the researchers to please figure out what this might be, but I didn't get any hits of what was going on with this young man, until he brought me a newspaper article. Remember, the patient is the most interested person in solving the problem. They will be a partner with you if you let them. And so he brought this newspaper article about a young man in Northern California who had a very similar presentation. And so now I could hit the questions, and I could put the word Lyme disease in that. So I found a case report for patients with MS-like lesions. They had chronic meningoencephalomyelitis caused by a tick-transmitted bacteria, Borrelia burgdorferi. First, in honesty, that I had heard about it. So I called the author. What do you do if you're primary care and you need information? And the author said, well, treat him. You've either got someone with a degenerative neurologic condition or they have Lyme. It was so much easier way back then that if it's Lyme, in 30 days, you'll cure him with the Rocephin. If not, you won't cause him any harm. So indeed, he felt much better. He could walk, he felt good. This 30-year-old male traveled home to visit his mom, who even at 30 years old had the clout to make him see a neurologist. And he saw probably the only neurologist in Texas who ever treated Lyme disease, Dr. Stein Goldings, who put him fortunately on a year of doxycycline and probably helped cure this young man. But what that did for me was I was aware that there was a disease that wasn't explained. And I want to again talk about the value of case reports. Over the next few years, the 89 to 95 timeframe, I had patients come in with all these strange things. My third line patient was an MIT student. You could look at her chart at MIT, her medical chart, and see the onset of the Lyme. Had to drop cross country, had to drop a class. Her incredible A's turned to B's. And she had trigeminal neuralgia. And there was a case report of trigeminal neuralgia, sudden deafness. I had a panic psychiatrist come in. She lost hearing in one ear. She had read that she could lose it in the other ear, and it could be caused by Lyme. And so with all these things, I started looking hard at the literature, especially case reports. I had, at that time, if patients were ill, and they had an EM, I treated them with doxycycline. If they looked like they had Lyme disease and it was serious and neurologic, I sent them to the infectious disease doctors, who usually put them on IV, and we moved on. Suddenly, mid-90s, the ID doc sent me back the patients, and they said they don't have Lyme disease. At that time, I didn't know about the Dearborn Commission. I didn't know what was going on. But I had a detective who was first on the scene of violent crime for the past 10 years. I said, well, do you wear masks? He said, no. I said, do you wear gloves? He said, sometimes. He also hunted, and he also stuffed his own animals, right? He did taxidermy. So I thought, okay, I've got a positive Lyme test, but what else does this guy have? So at that point, I asked him to go see the ID doc, and it was late enough in the story that I said, please don't tell her you have Lyme disease. I can take care of the Lyme disease. I want to know what else you have. He walked in, he said, I have Lyme disease. She sent him back to me and said, he doesn't have Lyme disease. You figure out what he has. So at this point, I thought, what do you do as a primary care? I thought, I misread the literature. I've got to go back and read the literature. And that was quite a revelation. So my 1995 to 2001 time, I call them the cowboy days, because what I was finding in the literature was that this is an organism that goes into the central nervous system early in the disease. This is Paxner. And that it seems this was about 4 spirochetes, leptospirosis, relapsing fever, Lyme, and syphilis. And for all of those, penicillin, high-dose penicillin was the proper treatment. But for the last 2, if you didn't treat syphilis and Lyme, then people could become very ill, and we didn't know for sure how to apply that treatment. Everything there, this is from Dr. Mao, Charlotte Mao, punchlines of this, the spectrum of Lyme disease. Ooh, and I didn't get the reference on there. I'll do that for you if you talk to me. 3rd stage has no CNS markers. There's no pleocytosis. At this time in my practice, I was being told to please do CSF, and if there wasn't any white cell and there wasn't any evidence of infection, then they couldn't have neurolyme. The comparison with syphilis makes us feel that in almost any undiagnosed neurologic problem occurring in an endemic area, Lyme disease must be considered in the differential diagnosis, particularly because of its potential in response to penicillin. This was 1986. The bug was found in 83. So when I was reading this in the 90s, right? But if you look back in that 91, 89, everything said treat with penicillin, treat with ceftriaxone, this one expanded, or tetracycline, because the best fit is persistent infection. So at that point, I thought I didn't make a mistake in what I was reading. And I did treat people with very high dose IVs with very good success at this point in time. There was no case definition, but Legigian, Steer and Kaplan in 1990 did this beautiful, for me, case definition of what Lyme subacute encephalopathy is. Forget names. 10 patients had symptoms of depression. 8 had excessive daytime sleepiness. They were talking about my patients. 7 were extremely irritable when before it just would have annoyed them. Finally, 5 patients had subtle symptoms of language problems. Again, Legigian and Halperin, our preliminary MRI and CSF studies suggest that this is encephalopathy due to a low-grade encephalitis. And we, most importantly, have demonstrated that defects in both nervous systems, CNS and peripheral, are reversible to proper antimicrobial therapy. The other things these early papers did, and they're so well done, they describe each patient individually, each test on each patient, is it gave me things I could look for that would help in my scale of, is this Lyme? At that time I was saying Lyme, not tick-borne disease, or is this something else? I could add things to the scale. So the MRIs showed what was then called unidentified bright objects, and are now glial scarring or microvascular insults or clots. High protein in the CSF, low white count. You didn't get high white count. And there's even a paper comparing viral meningitis and Lyme meningitis, where it says that 0 to like 200 in your Lyme and over 2,000, 3,000 in your viral. Neurospec became very valuable for me out of the Legigian papers. I use it to this day. Think of it again and again, like neurosyphilis. You're probably all aware that Packner wrote a paper called The Second Great Imitator, which was about Lyme, the first great one being, of course, syphilis, because it's a neurologic infection that's non-selective. And then the neurocognitive testing that came out of Columbia really helped me, especially with children at the time, to get them treated and to identify when they were better. I put this in here to also say that the exam room became very important, and to this day I find it very important. In about this time, the late 90s, the word objective symptoms versus subjective symptoms came up, which is crazy to me. I'm a primary care. I want to get the subjective symptoms, figure out what they are before they become objective and not let them become objective. But this is not a normal hand. This taught me about ACA, though this was an American-acquired Lyme. So 2001 to 2009, it seemed clear to me at this point that there was persistent disease, that really there was infection. But why? You know, at this point, there was much more opposition to me using antibiotics. You know, it was called into question because of this concern of superbugs. Some patients started to fail the IV treatment. I started to think about the clever bugs, and more patients were appearing at my door as more and more doctors diagnosed them with multiple syndromes without a cause. So the elephant in the room was obviously co-infection. What I did at some point was go to the literature to try to figure out what really causes resistance to spread. And the reason was, I remembered from my medical school, from my infectious disease 101, that the problem was not treating a bug long enough or with high enough antibiotic to really eradicate the organism, as opposed to select the partially resistant ones. So that's what I found to still be true. I first looked at the biome, how does it develop? And there's a lot about that in the literature. Then there was this question of how do you tell what's commensal, symbiotic, pathogenic? what's the dynamic between those things in terms of your bugs? And I think that's something we need from the bench, to understand that dynamic. And I certainly thought that withholding antibiotics was as dangerous as giving them. So the question was, if you have the disease and you withhold the antibiotic, what's that risk? Versus if you don't have the disease and you give the antibiotic. And I started thinking, let's balance risk and be honest about it. Misuse of antibiotics can select for resistant bacteria. And in the States, the biggest misuse is in low doses of growth-promoting antibiotics, very low doses to promote growth in your farm and ranch animals. And it's still allowed in the States. It was forbidden in Europe in 2006, although I've heard there are ways around it. And I think this is the main reason we have resistant bug. And that was my conclusion at the time. There's also a problem, again, with selecting out those partially resistant ones. And again, I learned in med school that was because some countries don't have the ability to treat things like TB adequately. And so you end up with multiply resistant TB. The question of what makes a microbe share plasmids, I think, is also important. I'm sorry, this is a Mac to a PC, so things are formatted a little differently. So I said this already. We need to know what makes a stealth bacteria go rogue and become a pathogen. And it's interesting about the adaptation that I think Dr. Berry talked about, because maybe that's it. Maybe as they persist, they adapt, and then they can become pathogenic and grow. What are precision medicine? What is the genetic makeup? What are the SNPs that might lead to it? I've said that one already. And then can we get to the point that we understand how it all works so that our antibiotic stewardship can be realistic, that we can treat people with infections safely? That's where we need to go. I have to acknowledge that in learning how to treat an emerging disease, also colleagues who have gone before are very helpful. Joe Berscano put on the budding internet in about the mid-90s his advanced topic in Lyme disease. And again, a patient brought it to me. I called Joe because I wanted to acknowledge when these started. And he said, interesting, I'll look at my files. And he said his first one was 1982. So that was before the internet, but I came into it when it went on the internet. And what this did for me was it made me say, oh, I've got to understand the organism. You know, I've got to figure out where the bacteria goes in the body, what the microbial morphology is, what's the distribution, and then the kill kinetics. Joe talked a lot about this in iLab. What's that area under the curve? How long you needed that antibiotic to affect a minimal bactericidal concentration, and how do you get it where the bug is? So this began a research on my part that helped inform me how to treat my patients. I figured I needed a model of what was going on before I could treat. Then I also have to acknowledge Brian Fallon. He wrote a paper in the late 90s called The Underdiagnosis of Neuropsychiatric Lyme Disease. At that point, the paper is coming my way as a family physician where, oh, it's being overdiagnosed, Lyme is being overdiagnosed. And Brian acknowledges that in this paper, but says there's also an underdiagnosis. And again, gives 3 amazing case reports. So this opened my eyes to the psychiatric issues. So moving forward, I'm looking at what's this bug doing? And Brorson, I think in Norway, they found that the spirochete could turn into a cyst. So you have a little culture of the bug, you throw in doxycycline, all the spirochetes go away. This is a family practice understanding. But these little blebs appear, you take the blebs, put them in a clean medium, and lo and behold, they go into spirochetes. And they were called cysts at the time. What Borson did is basically sensitivities. They showed that metronidazole, tinidazole in vitro, and grapefruit seed extract all could prevent or eradicate that persister, what we now call a persister and was then called a cyst. And then Oksi's work in the late 90s also was part of my cowboy days, because what Oksi showed is that you can improve the outcome with patients by giving them longer-term antibiotics. But he also showed that patients fail. They fail both the longer term, but more fail the shorter term. And he showed that with direct testing, with PCR and with culture. And this now started my explorations into this bug. Why does it persist? What's going on? What outside of the bug is contributing? This is Paul Ewald, who wrote a seminal paper. He's an evolutionary biologist. And basically, this is a concept of what causes a disease. So you're born with a certain genetic. Certain environmental epigenetic insults can happen to you along the way. So you get these DNA adducts. You can't transcribe your DNA properly. And then what was new to me is the infections come in and evolve in this system. So his example here was chlamydia pneumoniae. If you have an APOE4 gene, if you smoke, or if you get a chlamydia pneumoniae, all of those things had been put forward individually as causing atherosclerosis, but the math didn't add up. If you put the three of them together, the math adds up. And if you have all three of those factors, you will get atherosclerosis early on. The next paper that really made a difference to me was stealth pathogens. And again, this is primary care trying to figure out what the heck's going on. And these are frontal attack and stealth. This table I'm using courtesy of Dr. Breitschwerdt, who adapted it from Merrell and Falkow, and it's so much better than their table that I'm using it. So these again started to describe my patients. So frontal attack pathogens, they have a very short incubation. You get strep throat from your brother, you get it in 3 or 4 days. Stealth pathogens, long, months to years, and that's what was happening. They had an illness, or perhaps they don't remember the illness, or they had a tick bite, and months to years later, they're coming in sick. Acute symptoms, chronic symptoms. They come, they relapse, remit, and they get more and more frequent until they're always there over years' time. Sterilizing immunity versus non-sterilizing. And these bugs are smart. They do evade the immune system. Lyme stops the complement kill when it comes in. It's just a very adapted bug. So you get non-sterilizing. You can get Lyme multiple times. Transmission is direct with your frontal attack. Indirect, it's stealthy, right? It comes through a tick or a mosquito or a vector or a flea. Replication's rapid in the frontal. They try to outrun the immune system. They're outrunning the white cells, but it's slow and sneaky. They're hiding, right? They're stealth. They're coming out of the mountains to strike and back in. Carrier states uncommon in the frontal and very common in the stealth. And then this is Garth Ehrlich's work. He let me use this slide. This opened my eyes to really the potential of biofilms in the body, which I had been reading about probably for the previous 5 years. But he did work on Haemophilus causing ear infections in children. And when I was in med school, I was told it's all viral. You can't culture bacteria from it, right? But it turns out it's mostly bacterial, but you can't culture it because they're in biofilms. What's interesting is he talked about not only polymicrobial infection, biofilms in the body that are stable and protecting our good guys are always multi-species, right? They have some fungus, they have some gram-negative, gram-positive, and they also have the eukaryotes in there. But what I didn't know was this polyclonal. So in those Haemophilus biofilms causing otitis, there are many, many clones of Haemophilus, and they seem to be able to share genes laterally. which again, I think of it as a superorganism, like an anthill or something, that where really it becomes more than just an individual infection. So what do we need from the bench? Have tick-borne diseases evolved for any genetic fingerprints? The HLA typing that's looked at. Why do women get more chronic tick-borne disease than men? And a lot of us suspect that the MTHFR, that a methylation problem, seems to result in chronic, but we need controlled studies. And do stealth pathogens, can bugs themselves create DNA adducts? Can they cause epigenetic changes? And again, which of those might lead to persistence? So the other thing Paul Ewald wrote in that 2000 paper is he talked about this idea of an end host chronic infection. Again, taking chlamydia as the example. So a chronic infection in a host that won't spread that infection may be something that you can treat without fear of spreading resistance. And if chronic chlamydia is not communicable, then can we develop targeted antibiotics that will remove it? And will that protect the person from MS, from spondyloarthropathy, et cetera? And the reason he stated it was an end host without spread is children in general acquire chlamydia when they go to school, when they are in a multi-person environment, not when they're in, when they're at home being taken care of by their chronically infected patients. And again, he argues that if we could understand really the behavior of infections, then we could sensibly apply our antibiotics, not simply say, don't give them, which is what I hear all the time. And then this also relates, I think, to a previous talk in that Ewald notes that when you have acute chlamydia infection, you get TNF alpha, you induce TNF alpha, and it appears to help control the infection, right? It does what it's supposed to do. But what are we doing with our spondyloarthropathy? We're giving TNF blockers right and left. So does that allow setting up of chronic infections? We know that steroids in Lyme, we know this again from those very early papers, results in a harder time to eradicate that bug, more persistent infection. What about the other immune modulators? And this is something, again, I hope can be set up in studies so that I, as a doctor, can know when I can safely relieve someone's pain with a TNF blocker, but not set them up for a persistent infection. And I just put this in, and I didn't cite it down at the bottom, but it's in the references. Carter basically tapped joints in post-infectious spondyloarthropathy and found PCR positive chlamydia, pneumoniae, and trachomatis, and did a 3-arm trial. And basically treating those people with antibiotics resulted in much more improvement than with the placebo group. So the question is, people you don't have PCR positive, maybe it's in the synovial sheath, just like it is with Lyme. And what if you treated them and we need a study? Another paper that made a huge difference to me was Dr. Breitschwerdt, who I think is talking tomorrow to this group. And he wrote a paper in 2013 about Koch's postulates and how they need to be modified given the modern world we're in, where we can do PCR to RNA and DNA. And he reviewed the suggestions up to that time of how to modify them, and specifically said, here's how I would apply them to Bartonella disease. And basically, you identify organisms in sick tissue. And if there's Bartonella in tissue that is sick and not doing well, but no Bartonella in your healthy tissue, then that may suffice to say, okay, we have a cause of disease here. I put these here because they were such a big part of treatment from the 2004 to probably 2015. And what was constantly said in my family practice conferences is, oh, there have been 4 randomized clinical trials and they all failed, so you shouldn't retreat people ever. This is DeLong, who is who basically reviewed the trials and commented on them from a statistical point of view. She's a statistician. And this simply is not what those trials showed. Those trials showed improvement in the Fallon and Krupp trial with fatigue, huge thing for a tick-borne disease patient. Improving their fatigue lets them go to their children's activity, lets them go back to work part-time. And Fallon, of course, if you've read his trial, cognitive improved. It did a little bit in Krupp too. And Klempner simply was statistically poorly designed. So at this time, this became a big issue. And one of the things I think we need as primary care docs is I think we need the researchers presenting at our primary care conference, with a status update. Here's what we now know about this bug, and here's what we don't know. So we don't just get a cookbook definition, a guideline that does not, in general, help the patient. So 2010 to 2023 has been, I think, an exciting time in tick-borne disease. It seemed to me up to then that the really good research was that early research, that maybe 1984 to 1999 or something. And the CDC somewhere in the early 2000s said, we know everything we need to know about treating, we aren't funding anything more. So what was lacking in this time frame, there was no dual infection or multiple infection type of studies. And patients with late Lyme disease, if you look at what the IDSA, which is our infectious disease organization, cited for treatment, those studies had very, very few chronic patients in them. Oh dear, I'm way behind. So at this time, Maloney, I want to mention, because she really makes a case for clinical diagnosis and for the need to go back to that exam room. And almost 50% of my chronic patients will at some point show facial palsy. And you have to look closely, and it comes and goes. And you can also find asymmetric other cranial nerves if you do your work. I mentioned Bob here because he really helped me with a lecture early on, again, about a model of what's going on. What you have is irritable neurons because the infection with Lyme specifically is in the neuron. I remember Paul DeRay early on, a pathologist, saying I wanted to know, was the infection in the neuron or was the infection in the vessel? And he found that it was in the neuron. And that's why you see these constant compartment syndromes in this, because it's in the nerve sheath. So co-infections, we need more information. Swanson in 2006 did a great review of infections in Ixodes ticks and basically said, look, we know a lot about the individual infections. It's time to look at what happens if there's more than one in people. You can't culture most bugs. You guys probably know that more than I. And so how do we confirm with direct testing? I think Dr. Mosiani follows me, and he may talk some about that. At this time, Shappy figured out how to speed up growth of Borrelia by shaking the cultures. And later, Zhang took that, and both of them did in vitro sensitivity testing, which really was a game changer for me as a clinician. I could argue with insurance finally and get people covered. There's a triple drug paper that basically Zhang says we eradicate both the persister and the bug. Again, Dr. Embers just talked to you, so I won't dwell here, but thanks to her, we have primate models, and we have applied, say, Zhang in vitro model to a mouse model. and she's now working on a monkey model, which she presented a little bit today. Dr. Breitschwerdt has really brought forward Bartonella as an infection, and he has written many case reports where there are co-infections. I didn't cite them, there's so many of them, and they're excellent. There is, what happens if someone comes in to your office with more than one infection? This is a man who came into the Duke emergency room, fortunately, twice. They sent him home the first time, came back somnolent the second. And he had a rash, and they biopsied that, took blood. He had a fourfold change to Ehrlichia, but under the scope, they found rickettsia. Rickettsia never really mounted an antibody response. 55 days later, they had a 1 to 40 titer. But had it not been Duke and someone hadn't punch biopsied him, how would you know he had Rocky Mountain spotted fever, which can kill him in 9 days? So the final two I want to leave you with are case reports now, I call them, and they're really small series. Trias, and forgive me if I'm mispronouncing this, just published a paper about treating patients and acknowledging that they're multi-infected with Babesia, Bartonella, and Borrelia, and treating them for up to 2 years with a combination of IV and oral antibiotics. 7 out of 10 patients cured. 2 years later, still well. And I think it is that kind of approach, that case report now, or that series, should now be brought forward for a controlled study, because it made me think, you know, those cowboy years I mentioned from 95 to 2001, I think I should maybe be going back to them and treating people vigorously and long-term. I've been doing shorter-term courses. Novak and Zuchevich also wrote a great paper about dysautonomia. And again, what they did is they only took patients out of 167 patients, they found 10 that they could unequivocally diagnose with Lyme based on CDC guidelines, because they didn't want an argument that these people didn't have Lyme. Every one of those people had autonomic dysfunction. And so again, as a clinician who's a primary care, can I order a small fiber biopsy and get it paid for? Now with this paper, you know, I can do my tests on the patient. So hopefully we need models of infection. We're getting them. We need to think about the new data and how to apply cost to it. And I thank you.